Hey guys, it's Elizabeth. This is a very special Friday early morning edition of The Naked Truth, and I'm here with Dr. Matthew Weiner. Hi. And thank you so much for doing this. People don't, I sent him an email, he responded so quickly. I'd had his business card sitting in front of my computer for a year since WLSFA last year. So I'm really thrilled that you could join us.
It's great to be here. Thank you everybody for waking up so early in the morning on the West Coast.
Yes, and so we have a couple people already in chat. Zen Maiden is here, CJ Shrink, Losing It For Me 42, Susie VSG, and Shelly's Losing to Live. Thank you guys for coming out so early. And for those of you who can't watch the whole thing, this will be on YouTube, in perpetuity, like my other 9 million videos. So I'm just gonna jump right in because we got a lot of questions from people, and I think we could probably be on here for like 3 hours if we went into detail on everything. So first, do you just want to give a little bit of your background for people who may not know about your practice and why you chose this field?
Sure. So I am a private practice surgeon, which is kind of a dying breed. I'm kind of looking for the chat at the same time. Okay, here we go. All right, so I'm a private practice surgeon, which is kind of a dying breed, but I'm really committed to maintaining my independence and not feeling like I have to serve a hospital or do so many cases in order to meet my quota and go into some 25-year-old administrator's office and explain to him why I haven't done as many surgeries this past month as his budget says I should. So I'm really committed to my independence. I started out as general surgery. And I loved the abdomen and I loved the surgery, and kind of as a younger guy I was really excited about the blood and the guts in the middle of the night, life-saving that a general surgeon does. And it's great, but it doesn't really go great with having a family and being a good husband and being around.
Yes, as the daughter of a doctor who started out in surgery, I understand that.
Yeah, I mean, being a general surgeon is a tough life. Right around that time, bariatric surgery was just kind of converting over to the laparoscopic approach. I had been doing a lot of laparoscopy, and I, thought, oh, why would I want to do bariatrics? You're not saving anybody's life. You're just helping people get thin. Very superficial view, as most of us did back then, and a lot of people still do now. And then I saw the surgery, and the surgery is it's an awesome surgery. It's really elegant. There's a lot of complexity to it. I just fell in love initially from doing the surgery. And so I started doing.
So you started doing lap bands, or are you talking about the sleeve? Or?
I was talking about gastric bypass back then.
Okay. Oh, gastric bypass back then. Okay.
I was doing lap bands too. And the lap band surgery is not nearly as interesting or challenging as a gastric bypass surgery. And so I was kind of really enthralled with that. And so I started doing more of it, and I kind of got into it. And I was initially, had zero training in nutrition or how to counsel someone on a diet. And I was putting people on protein shakes and counseling them on counting calories and kind of berating people. I actually was just reminded yesterday of a patient who I had seen the first time I saw her was probably 7 or 8 years ago. And she reminded me that I kind of gave her a hard time one day. She almost didn't come back to see me, but she wanted to give me a second chance. And ended up, she was a band patient. I revised her to a gastric bypass, and she'd done so well. It was really just after about 6 or 7 years of kind of struggling with her band, finally it lost over 100 pounds with a revision surgery. I was so happy and doing so well and exercising and doing everything right, and really just a great patient. She kind of reminded me that I was a little bit of a jerk back then, and she was right, I think. But over time, I started to do more of these surgeries, and I always say that I realized there was something wrong when I had a clinic, and I had like 4 or 5 patients, and they all kind of told me the same thing in terms of their nutrition and their weight loss struggles, and it really contradicted this calorie balance, willpower model of obesity that we had been taught and was just the standard dogma. And I thought to myself, man, either these guys are meeting in the parking lot and getting their story straight, or maybe there's something else going on here. And it was right around that time that we started to see the first literature on your body set point, and I started to follow that literature, and I watched a bunch of talks and went to some classes on it, and it was really, really just eye-opening to me, because it was like, wow, there it is. This explains what everybody's saying to me. And finally, the science was lining up with my patient's stories and experiences. And I also realized that instead of this kind of being a paternalistic, like, why aren't you eating better type of relationship, which is no fun for the patient and really no fun for me either, we could partner on this. And as soon as I kind of started approaching my patients from this set point perspective, then we became a team. And that was really fun to me. And while I initially fell in love with the surgery, it was in the end being a surgeon, but also being able to maintain long-term relationships with patients. Again, yesterday I saw a patient, I've known her for 6 or 7 years. That's like your primary care doctor. Right. And we've been through a lot together. Developing those relationships is
that's
really
kind
great.
of interesting to me, and I picked that up from your videos and from hearing you talk a few times. I mean, it seems like you may be a little more involved post-operatively than a lot of surgeons are.
Well, private practice kind of drives that, right? The whole healthcare system, I don't know if you're aware of this, but it's a little screwed up.
Yeah.
Have you caught wind of that? Yeah, it's a little screwed up. And what's happening is that basically everybody's kind of figuring out how to game the system. And in some markets, actually in our market in southeastern Michigan, there are several hospitals that are just reimbursed excessively for these surgeries. For one night surgery, you pay $35,000, $40,000, $50,000. And so what happens is these administrators are sitting around crunching the numbers, say, hey, this number looks pretty good. We can increase the bottom line. Let's crank through and get a bunch of cases going. And they essentially create this program. They hire this surgeon, and the surgeon's job is just to do surgery. And they hire the team of nutritionists, and they're all well-intentioned, but in general, the goal is as many surgeries as possible. And in private practice, I'm kind of not driven by those same guidelines. And it allows me to meet with people and kind of practice at my own pace. And believe me, I love to operate, and I operate on plenty of people, but not everyone. And I don't look at everybody coming in as like, okay, let's figure out how we can get this person to the operating room as quickly as possible. And so I think that just the economic setup I have really dictates that I'm much more involved and much more available to my patients. And I don't have this whole army or team behind me that I can hide behind. It's been a real advantage, I think, in my clinical development and in developing my relationships with my patients.
So, boy, I hope you'll come on again, because I just know we're going to get through like 5 of these questions and then we're not going to get through everything. But can you talk, because not everybody may know your, like, the set point perspective that you were talking about. Can you kind of explain that and what your theory or why bariatric surgery works?
So in one of my very first medical school classes, it really was first semester of my first year of medical school, we took physiology, and the very first chapter of physiology was titled homeostasis. And what that means is keep things the same. And our body is incredibly well designed to keep things the same. And we have these feedback loops. If your body temperature goes up too high because you're exercising, you start to sweat, your pores open up to let the more heat out. There's like a million things that happens in our body to maintain that body temperature at 98.6. And what this chapter really said was that this is how your body works. This is everything. It's your temperature, it's your blood pressure, it's your blood glucose level, it's your breath rate, it's your oxygen level. You name a parameter that can be used to define our physiology, and it responds to these feedback loops that help to maintain things the same. However, body weight, we've always thought, well, if you eat more calories than you burn as a conscious decision from being sedentary and not exercise or overeating, well, your body weight goes up. And it's just a simple mathematical equation. There's no homeostasis in this model. There's no feedback loops. There's no, if you eat too much, your metabolic rate increases to keep the balance the same. And if you look at the vital functions of a person, of a body, maintaining your fat stores and your calorie balance is critical. If you're a caveman and you're not interested in food, you're a dead caveman. And if you're a caveman and who can't make it through a long, cold winter on 600 calories a day, you're a dead caveman. So to think that somehow body fat is immune from these same principles that guide our entire the entire physiology is, I think, foolish. And the set point model essentially says is that just like we have body temperature, blood glucose levels, blood pressure, we have fat store levels, which we kind of loosely dictate to body weight. And these fat storage levels work to maintain the same. If you get sick and have a cold and you lose 5 pounds, as soon as you recover, your body works very tightly and you'll regain that 5 pounds in a week. And there's an incredibly rich and robust set of mechanisms designed to keep those fat stores the same. However, just like with our blood glucose level, where these measures can break down and we see an elevation of your blood glucose level, where a diabetic doesn't have a baseline sugar of 100 or 110. Instead, they have a baseline sugar of 200 or 210, and we have to do prescribed medicine and make diet adjustments and do things to try to bring that baseline down to a normal value. We see the same thing happening with our fat stores. And it's a very similar process to what we're seeing with diabetes, where instead of that normal body weight for a woman of 130 pounds, we're seeing it go to 140, 150, 200, 250, 300 pounds through a variety of mechanisms. And we have to recognize that our body weight is that some dysregulation of these fat stores. And what bariatric surgery does is, if you're starting out with a set point of 250, it may lower that set point to 150, just like medications can lower your blood glucose from 250 to 150. Surgery can lower your body weight from 250 pounds to 150 pounds. And it makes these changes initially in your brain, and then over the next year or so, your body adjusts by decreasing your appetite, increasing your metabolic rate to bring your body weight back to where that set point is. And then you get to live at that 150.
And where does that number, how does your body determine what number that's going to be? Because I've sort of seen people in the community who like lose like 60 pounds and that's it. It's not, and they try so much harder than some of us who have been able to lose a lot more weight than that. So where does that number come from?
That's a great question. Where does it come from? Our best answer is it comes from your genes, your genetics. Yeah. And if there's one question I can ask a patient that will predict whether or not he or she will succeed or not succeed after surgery, it's, do you have a first-degree relative, like a parent or child or sibling, who has had weight loss surgery? If so, what surgery they have and how they do. And when I meet someone who's like, my mom had a Roux-en-Y 10 years ago, and she's still 150 pounds, and she did awesome, I say, okay, guess what? That's what we're going to do. We're going to sign up for the same thing your mom had, because chances are you'll do just like your mom did, and she did great because her genetics are more favorable.
Mm-hmm. Yeah. Do you have any, I feel so bad for these people who work so hard. And I mean, things like, well, you have a set point smoothie. I don't know if you want to talk about, but what are there things that those people can do? Because I just feel so for them.
It's devastating.
Yeah.
Devastating. We're seeing it more with the sleeve patients. And I think that's something that is very important for anyone considering the surgery. I've seen sleeve patients lose, go from 320 to 290 after surgery.
Oh.
Yeah, I mean, it's, and I study them, they got a good sleeve.
Right.
It's not that the sleeve is too wide. It's that this surgery, this treatment isn't particularly effective for this patient. You see another patient go from 320 to 150. And why that is, it's not their behaviors. It's not their compliance level. It's something in their genes.
Right.
So what can you do if you're one of these people who've lost a little bit of weight, not nearly what they thought? You can do everything you possibly can, and you can also consider revisions. I've had a few patients who I've then gone on to revise to gastric bypass. There's this new procedure coming out that's kind of labeled as the SIPS. If any of you are interested in being guinea pigs, you could explore that option, but it's totally experimental and under study, and really it's probably a good surgery, but there's a lot of, it's not a simple, oh, this new thing is amazing. but I've converted a bunch to Roux and Wise, and they've done okay. You know, again, they don't knock it out of the park, but there's maybe another 50 or 60 pounds of weight loss to get to a better place. That's probably your best bet at that point if it's a sleeve patient who hasn't lost enough. There's a big difference between not losing enough and regaining. Those are two different processes.
Yeah. So I joke that I was 400 pounds. I've lost 200 pounds and on it with a sleeve, and have been, you know, and I think I'm probably more compliant than most. And I've exercised from the get-go, strength trained, and my habits are pretty good. I'm 3 years post-op, and that's it's sort of when, but I'm up like 10 pounds and I still never hit my goal. And I was joking to my friend the other day that, you know, my other friends who he gave RNY to already met their goal, but I don't think I have much of a case having lost 200 pounds on the sleeve. But what do you think when you're 3 years post-op? And I still have 20 or 25 pounds that I want to lose. And it's like so funny because 20 or 25 pounds at 400 pounds would have taken me like 3 minutes.
Yes.
And now it's like the hardest thing ever.
Yeah. So, you know, I have this conversation all the time. Very few people get all the way down to, say hi to Mary.
Hi.
How are you? Very few people get all the way down to their ideal or goal weight. So what do you do if you're 25 pounds away? And so I think the first thing is, you know, again, kind of recognize there's 4 ways you can lower your set point. Through surgery, that's already done. Through better nutrition. And so at that point you ask yourself, can I make my nutrition better? Now, you know, nutrition is such a spectrum, you know, it's not this binary thing. If you have one potato chip but are otherwise really super compliant, you're still really super compliant. It's, you know, where are you on that spectrum? We can always push it better. I mean, there's probably very few people out there who are a strict vegan, which is probably the ideal and optimal way to lose weight. But man, it doesn't sound like much fun to me. It can be done, and if you can do it, fantastic. And so first question, can you push your diet any further and do it? And maybe the answer is yes, maybe no. But that's a personal decision. I can push my diet further to get a little bit of weight loss, but then, you know, I don't want to eat that way for the rest of my life. It's a struggle. But I get to lose a little bit more weight. So that's a real personal decision. You've done amazingly well. And, you know, could you go further with the diet to get those 25 pounds down? Yes, but would that be worth it to you? Maybe not.
Well, so let me ask you a question, and then we'll go back to the 4 things, because this is, you know, keto is going wild through the weight loss surgery community now. And I got to tell you, it's the only thing, it's the only thing that's moved my, it started me losing again. What are your thoughts on that? I know it's.
What do you mean by keto? Just
keto is low carb, moderate protein, high fat.
Okay. So, I mean, that's kind of the origin of bariatric surgery, of the high animal protein diet. You know, the first thing about any kind of ketogenic diet is, and any type of diet, is that if you look at it like, okay, I'm going to lose that weight and then I'm going to go back to what I'm doing, it doesn't work that way. So again, if you want to lose another 25 pounds, going on some protein shakes, and kind of reducing the calorie consumption, eating high protein, some type of kind of extreme diet modification for a temporary period of time is great. And you know what? If you have a wedding and you want to look good in a dress and you want to lose 20 pounds, that's a reasonable thing to do for that wedding. But don't go buying all new clothes once you get down there, because, you know, the chances are about 99% you're going to go back up. And that kind of yo-yo down, up, down, up, down, up typically results in a slow escalation of the set point. So you usually don't go you don't go back up, you go back up plus a few. So there's risks in doing that. So when you're looking at a short-term weight loss, yeah, ketogenic diets work great, but live for the rest of your life.
Yeah, no, and that's where my struggle is, because it absolutely does work. But I sort of believe, I don't like the idea of anything being restricted. I sort of follow the 80-20 rule, that 80% of the time I'm eating very well. And so I don't know, but we'll see. But a lot of people, that's what a lot of people in the community are doing now. And I jumped on the bandwagon just because even with calories and exercise, you know, monitoring my nutrition and stuff, but this isn't about me, but I know a lot of people ask me to ask what you thought about keto. So, but sort of like Pound of Cure, I would feel the same way. I don't know that I could eat that way my whole life.
Again, it's kind of a, you know, I created a smartphone app, which is, it's not a great app. The concept, I think, is very, very solid. The implementation of the app, I'm a better surgeon than I am app designer. But the concept I call your calibration.
Right.
And it really, I think it represents this spectrum, which is where all of us live. And if you follow the Pound of Cure perfectly, you know, and even get rid of any refined oil at all with my diet, usually I give it, you know, a little bit of oil in it.
Mm-hmm.
Get rid of any refined oil, perfect diet, you're scoring 95, 100%. That's fantastic. You're eating cheeseburgers and French fries and drinking pop all day, you're at 0%. But you can log your food and kind of see where you are on that spectrum. And the idea is, how far can you push your calorie ratio and still kind of participate in life and be social and not feel like an outcast who, like, okay, everybody eats this, but this is what I'm eating. How can you push that, and where will it take your weight?
Right.
And that's, I think, a challenge for every patient to determine.
Yeah. And okay, so we were talking about 4 ways you could change your set point. You talked about nutrition.
So surgery, nutrition, exercise. So the question is, can you push the exercise further? If you're young, in your 20s or 30s, then some of the high intensity boot camp, CrossFit type stuff is great.
Yeah, I'm 50 and I do that. 51. Yeah.
Good for you. Good for you. I mean, most people in that age range, they struggle with that.
Yeah.
But at a younger age, you can really do very intense exercise, and that intense exercise can help you drive the weight off. For most post-surgical patients, though, the exercise isn't that intense. It's kind of cardio, it's weights, but not crazy weights, and stationary bike, and maybe a spin class or yoga, which is all awesome. It's fantastic. But those types of exercises typically don't drive weight loss, but they are amazingly helpful at maintaining that weight.
Mm-hmm.
And then the final category is medications. There's just nothing great out there. I use phentermine or Adipex a lot in my practice. It's totally cheap, but if the diet isn't right, if the nutrition isn't right, it's a temporary weight loss. I also dose it down. I don't put people on the dose. Yeah.
It makes me a crazy person when I haven't taken it since surgery, but when I took it,
I dose it way down and keep people on it for a longer period of time, and it's much better tolerated. But you know, I see a lot of regain after we stop the phentermine. You know, right. It's only the patients who are super compliant who can maintain the weight loss through medication. So really, what do I tell patients who are 25 pounds away from their goal weight? I say, listen, I understand where you are, and it's great that you keep trying for that, but that is just a number. Yeah. We have to take a step back. First, acknowledge where we've come from and recognize that your real threat is not in not achieving this weight that you want, but it's in potentially regaining weight. So number one, anything you do to get you down to that weight, like a ketogenic diet, should not potentially compromise weight gain in the long run. So that's step one. Step two is that we should identify our true goals with this surgery, which is not to reach a certain weight, but instead to develop a healthy relationship with food and with your body. And if I really feel that the patient is doing that, I would discourage them from trying to get down those last 25 pounds and say, look at where we've come. Look at all that you've accomplished. You eat so well. You have stopped the binge eating and the fast food and a lot of the behaviors that most people are still doing, big or small, and made a huge change in your lifestyle. Look at your exercise. You're exercising. You're active. Look at what your medication list was before surgery. Look at what it is now. You told me about the 5K race you ran. Let's acknowledge those things. Let's be thankful for them. And let's not continue to feel dissatisfied with where we are in our lives with our body and our weight. And that's my major push for patients.
Yeah. And you're making me a little verklempt with that because my, you know, I mean, my life is way different now than it was at 400 pounds before.
I mean, what a blessing this surgery can be.
Yes. Oh, absolutely. I mean, and when you were saying in the beginning how you were looking at bariatric surgery as like, you know, well, that's not really going to change anybody's life. It's going to make it thin. I mean, I can't imagine many surgeries that change somebody's life as much as this.
Yeah.
Unless it's going to keep them from dying, of course.
Yeah.
So talk a little bit about what you think a good pre-op program is. For me, we had to do like 12 weeks of classes that I got no real information from. However, they made us lose 10% of our body weight, and it made me break those sugar addictions and carb, you know, that fast food addiction before surgery, which I think was really helpful.
Well, I individualize the pre-op program to everybody, and I think it depends on a number of factors. Some people come to me and say, okay, Dr. Weiner, how are we going to get this surgery done? And other people come to me and say, you know, I've struggled with my weight. I'm at a loss. I've never really considered surgery, but I understand you've got this nutritional program too. Let's just talk about my weight and see if you can help me understand this and see if we can help figure out a better way. And obviously one patient is going to get a different type of program than the other patient. But this person who kind of comes to me and says, I want to do surgery, how can I prepare well for surgery? In Michigan, most of our insurers require 6 months. A lot of it, you know, varies from state to state. We have some that are 3 months, and I'll kind of adjust the program based on the time frame. But I have 5 rules for eating after bariatric surgery. This is going to be this will come out in my new book, which I'm almost done with.
Yay!
I know, all on bariatric surgery. Really, kind of a compilation of all the videos and the advice.
Wow, so exciting. And I put a link on Facebook, and I'll put it in the video below, of all Dr. Weiner's videos. They are amazing.
Thank you. So there's 5 rules, and I work with patients typically 1 or 2 rules per visit, and we try to make some changes, and we see some weight loss in that. I'm not a big believer in the 10% weight loss, because I think that just gets people, the best way to do that is the shakes. You know, it's the most effective way to lose weight over the short run, and it's the least effective way to lose weight over the long run. And so it kind of gets people on this use this technique to get down a certain amount of weight to qualify for the surgery. But in the end, you've learned nothing.
What's funny, I mean, I did it by making small changes. So I started to eat cleaner, but what's so funny is we come into class that last day, and I'm like, oh my God, I'm like 1 pound off my 10%. Are they going to give me the surgery? And there were probably like 3 of us who hit the goal, and they gave everybody surgery.
Yes. It also, you know, it's also I think it's unfair to kind of do that kind of thing, because you know who really could lose that 10% easily? Someone who has a terrible diet going in.
Right. Yeah.
So when I look for a patient,
yeah, exactly.
When I look for a patient who's going to lose a ton of weight on my program, I look for the fast food and pop drinkers. Those people do great on my program. But a lot of my patients come in, they're like, listen, Dr. Weiner, I know you're not going to believe me, but I eat really well. I don't eat fast food. I eat almost no bread. I eat tons of fruits and vegetables. I read your book. The way I eat is not that different. Those patients are never going to lose 10% because they're eating well. So they've already kind of lost their 10% or haven't gotten up to that point. So it unfairly it treats those people who are kind of the better candidates. In my mind, people who eat well, that's a great surgical candidate. That's someone who, okay, listen, I don't have that much work to do. Just keep doing what you're doing with food. I do the surgery and we're good. So, you know, I really don't believe in that 10% mark.
Yeah. Okay, so are you going to tell us your 5 rules, or we have to wait for the book?
I'll tell you the 5 rules.
Okay.
You know, the first one's, if anybody who has read my book knows, pound of vegetables every day. And really it gets to the idea that you want to eat a ton of vegetables. And a pound is kind of a metaphorical amount, because a pound of cucumbers is really not that much, or a pound of carrots. But
it sure fills you up when you've had bariatric surgery.
It sure does. It sure does. But the idea is to eat as many vegetables as you possibly can. Eliminate or minimize refined sugar and artificial sweeteners. Not as bad, but bad. And eat as much fruit as possible. I always try to, you know, it's eat this, not that, instead of don't eat this.
Right.
The next is minimize the processed junk food, the granola bars, the chips, and all the stuff that we snack on, and instead eat tons of nuts. The fourth rule is eat lots of colorful starchy vegetables like beets and sweet potatoes and squash, and avoid the whites, the white rice, the white pasta, and focus, and in terms of the whole grains and the colorless starchy vegetables like white potatoes and corn. Those to me are a little bit of a variable for patients, but I kind of let them know, like, this is not a great food for you to be eating. Post-surgery, there may be space for this in your diet. There may not be, we don't know. And then eat less meat and more beans. So ideally, you're getting half your grams of protein from vegetable sources, ideally beans and nuts, and half from animal protein.
Great. Okay, I'm going to ask one more question that's sort of mine, but it also came up on chat just now, and then we'll try to get through as many of the questions we had from people as we can. And so a lot of us find, and I was like in intense therapy and had psychoanalysis for a year before. I mean, I have done a lot of work, but there is something about, I think to me, I think it shows up about a year after you've lost enough weight to make you, so to speak, normal, that I call the mental mind fuck. And it's about, I think it's multiple things. Number one, it's about dealing with all these, living real life and having more relationships with people and having to interact in the world when a lot of people who, like myself, who were super morbidly obese, sort of hid out in their house. So you have these real relationships and these real life issues that you sort of hid yourself away from before. And then you don't have your coping mechanism that you've used your entire life to deal with it. So do you kind of see that in patients? Do you have therapy recommendations or ideas on how to deal with that?
I'm really lucky. I have a fantastic therapist who works with our practice. She's had a gastric bypass. She's like 11 years out. She's a wonderful cheerleader.
Can we have her on A Naked Truth?
What? Oh, I would love to have her
on.
I'm sure. She's
I would
awesome.
love to do that.
Yeah, for sure. We'll swap contact info.
Okay,
Great. She would be great. So anyways, yes, she does her entire practice is just bariatric psychology. So she does all my evaluations, and she's there. It's, she looks at the initial evaluation, which we do for insurance purposes, as the introduction, because that's not when you need the help. You need the help when you talk. It's 6 months, it's a year. There's so many reasons why that happens, and she's certainly better off just talking about them than I am. But some things that I see are, that certainly people look at surgery and they look at their lives and they say, my job sucks because I'm overweight. My marriage sucks because I'm overweight. My relationship with my friends suck because I'm overweight. And if I just have this surgery, my job's going to get better. My marriage is going to get better. My friendships are going to get better. My life is going to be better in every facet. And that's not true. Your weight will be better. That's what it will do. You'll feel better. You'll have more energy. But chances are your job is, you're going to have the same issues. Your job probably isn't a problem because of your weight. And your marriage very well may not be weight related, those issues. And so what happens is oftentimes you get to that point, you've lost that weight, and it's like, wow, I actually have to confront these things. And that's a real challenge. There's also the term you use, which is a great term, which is the idea that you walk into a room and you still feel like you're 400 pounds. Mm-hmm. And how do you negotiate that? And all of a sudden you're getting attention, sometimes attention from the opposite sex and attention from jealous friends. And, there's oftentimes that person who's struggling with their own weight and they say, well, but Liz she's so much bigger than me, so I'm okay. Right. And all of a sudden you're smaller than her and you're a threat, and that relationship becomes complicated. So there's all these things that change after surgery, and, there's really no way to prepare yourself until you're in it.
Yeah.
And that's where a good therapist who has been through this with many, many patients, and in our case with herself, is able to help you get through that. But it's very common.
Yeah. Well, I would love to have her on, so let's definitely try to make that happen. Okay, I'm going to try to get through as many of these questions as we can. So Rhea Reloaded, who was with me in Nashville last year, so we saw you speak, even though, why did they put you so early in the morning?
I think I could get out of there. I think I know.
Oh, okay. But she said, you said something mind-blowing at WLSFA last year, which was, we are not so different from normal people. Can you expand on that thought?
Yeah, I think that's a lot of patients are told or believe that after surgery they have these unique medical demands that make them very, very different from other patients. And because of that, they kind of require this specialty or expert care. And kind of, I have some patients who call me and like, I have a sinus infection. Can I take Sudafed?
Mm-hmm.
Yes, of course you can take Sudafed. You know, 95% of the time, the rules for you are the same as the rules for everybody else when it comes to medication, when it comes to other surgical procedures, or anything else that's going on in your life. The rules are the same. And with sleeve patients, that's probably 98 or 99%. I mean, there's really very, very few things that make a sleeve patient unique medically where they would require special attention. Gastric bypass, there's a few issues. Things like iron have to be kind of treated specially. I'm really big on emphasizing to my patients that I'm your abdominal pain doctor. I'm your nausea, your GI doctor. And so patients 5 years out will go to see their primary care or a gastroenterologist who may not be as familiar with these procedures, and they may have a problem that I can figure out and identify and fix in a fairly short order, and they go through $1 million workup. The radiologist misreads a CAT scan, and things get out of control unnecessarily. So there are some things with a gastric bypass where you really have to stay in close communication with your surgeon, but those are few and far between. And so I think that's really what I meant by that.
Okay, and there was a question later on that I just want to touch on, which is NSAIDs, which with the sleeve, I was told, my surgeon said that was relatively okay unless you.
Yeah, I allow NSAIDs. In fact, that's a real deciding factor for me. Yeah. When I work with a patient who is pretty dependent on NSAIDs, and especially with our opioid epidemic, I'm really sensitive. Swapping an NSAID for an opioid is not a good idea. It's in fact a terrible idea. I always remind patients, you're here to make your life better, right?
Yes.
Opioid addiction does not make your life any better.
Transfer addiction is a real thing, people.
So anyway, I that if those patients, I really encourage to have a sleeve. NSAIDs after a gastric bypass, I think if you have a headache, you can take an NSAID, assuming you get a headache like once a month, like most people do. If you have daily migraines and you take 800 of Motrin every time you get a daily migraine, that's not okay. So it's really a dose-dependent issue. But I even get a little concerned with daily aspirin for cardioprotection. I've seen a number of patients develop some ulcers from that. So yeah, I'm pretty concerned about NSAIDs in gastric bypass.
But just
patients.
like occasionally taking it for a headache or whatever.
Occasionally is fine, but any regularity is it can cause major problems.
Yeah.
But yeah, I'm fine with it.
There were a couple of questions about that were related to Pound of Cure that I think you've touched on a little bit, and I'll put a link to your video on Pound of Cure and also a link to the book and the group. So I'm gonna skip those. Let's see. We talked about sorry, I should be. Oh, what are your thoughts on the use of probiotics for regularity and aiding in weight loss after weight loss surgery?
Great question. I think the pills are okay. There's a lot of variety. There's some that are probably better than others. My partner swears by the ones you have to refrigerate. He's got a brand that he takes himself. I'm a much bigger believer in probiotic foods than I am probiotic pills. Anybody who's kind of followed my videos or watched or read my book would recognize that would probably be my answer. So I love the kefir. I made my own kefir. I love the kombucha. I made my own kombucha. Yogurt, obviously, kimchi, sauerkraut, all of these foods that contain bacteria are probably really, really good for us. And we're starting to recognize that many of the impact, the set point lowering effects of these surgeries may be partially driven by changes in your gut bacteria. And there's a fantastic experiment where they took nude mice, which are essentially sterile mice who don't have bacteria in their intestine, nude obese mice, And they took regular mice and they that were obese, and they did a gastric bypass on them. Those mice lost weight. They put a feeding tube in these nude obese mice, took the gut bacteria from the mouse who'd had a gastric bypass, transferred it into the obese mouse with a feeding tube who never had surgery. And just by putting the gastric bypass bacteria in, those mice lost a significant amount of weight, almost like they'd had surgery.
Wow.
So it's very likely that there's a bacterial component. Now we're looking at the sleeve. What we see is an increased, a shortened transit time through the intestines. And somehow removing the stomachs the portion of the stomach makes the food go through your intestine faster. So we may also be seeing something similar to this with the sleeve.
That's really
It may be much bacteria driven as it is ghrelin and leptin and hormone driven.
So you did a video that I watched pretty early on that made me feel much better about which you talked about, like the common myths about bariatric surgery, like straws and like stuff like that. Are there a few favorites of those that you want to touch on?
Straws are one of my favorites.
Yeah.
It's just, and even because I'm part of a bigger health system at one of the hospitals I work at, like in our order set, it says no straws, and it's like 1,000 clicks to get rid of that order. So my patients still get a no straw thing, and they put a sign on the door that says no straws, which I like, because then when I go up to the floor, I know exactly where my patients are, so I don't have to look at the computer.
You don't have to look for room numbers. You just know no straws.
Even in my practice, people are told no straws, and it's just such an impossible myth to get around. But it's so much more important that you learn how your body responds to food, and straws may or may not create a problem. Every time you drink from a straw it hurts, don't drink from a straw.
Right.
But if you drink from a straw, it's fine. Okay, that's fine. Same with eating and drinking. At the same time, people put a lot of emphasis on this. It's an issue for probably less than 10% of all my patients. But for some, it is an issue.
Yeah.
So I'm such a bigger believer in people kind of figuring this out for themselves and learning how their own body reacts to different behaviors, and being very in touch with how things are going. Then kind of, here's the rules, don't do this, don't do that,
Right. What about the famous stretching of the sleeve? Does that happen?
It does happen. For sure, when you do swallow studies on sleeves after surgery, that we see them increase in size. And that's just the natural reaction of any kind of tight part of the GI tract. It will naturally stretch out. But what we don't see is that people whose sleeve stretches out gain weight,
right,
while those who stay at normal size don't. That is something that is not, I think, a true statement, and has not been shown with any kind of evidence. So the question of why some people after a sleeve regain weight and others don't, that's a very complicated question.
So I have to ask, because she's still here. My friend and temporary roommate, who's a nurse practitioner and a bariatric patient as well, wanted to know, what was it you wanted to know about PPIs? No, I can't find it. Like, what's the impact of taking PPIs, which I don't even quite know what they are long term.
PPIs are like omeprazole or Protonics or any of these blockers. So it doesn't impact anything really in any way related to weight gain or how your surgery works. I really try to keep patients off PPIs. In the first month after surgery, both sleeves and gastric bypasses, I put them on it. With sleeve patients, there's certainly a lot more reflux than we see with gastric bypass patients who have almost no reflux. So sleeve patients often find themselves on PPIs, and there's some studies that show 50% of sleeve patients on PPIs in a couple of years out. I think those surgeons are probably making the sleeve a little tighter than it has to be. I don't see that in my practice, but I certainly see 10 to 20% of my patients on PPIs long-term after the surgery. So I think you have to individualize that decision. And my goal is to not have people on it, but sometimes they need it. Anybody who has any type of ulcer after gastric bypass surgery, or for whatever reason may require a daily aspirin, or has some NSAID requirements that we just can't get around, I would absolutely put that patient on a PPI. There's been a lot of questions about alcohol. I don't know if you
Right, that was going to be my next one.
Okay.
On that.
So yeah, so alcohol is real. I mean, alcohol is a big issue. It's important, I think, also to separate sleeve and bypass patients. Sleeve patients, there may be you may become a little more sensitive to alcohol, but we really don't see the rates of alcoholism that we do with a gastric bypass. And you know, people talk about transfer addiction, which is where I was addicted to food, now I'm addicted to drugs or alcohol or something like that. I think that's probably not as accurate of a description as it could be. I think that the best description for gastric bypass is that the absorption of alcohol is dramatically different. Because now when you drink, it's dumped right into the intestines, and you can get a faster peak of your alcohol level and can be much more susceptible. And we all know people who like alcohol more than other people, right? I mean, I remember in college, there were guys who just ate, you know, it was like every night, what are we drinking? And then other people like no interest whatsoever in alcohol. There's a real difference in people's preference for this. And the people who really liked it when they were younger, they still really like it. They struggle with it. It can start to interfere with your family relationships. A gastric bypass can potentially convert you into someone who really likes it. One thing I counsel all my gastric bypass patients on, first of all, I think there's a 4% risk of alcoholism after gastric bypass.
Right, and you have Dr. Weiner has a video on this as well, which is great because it sort of challenges, it's like another myth, but where everybody said there's this huge percentage of people who become,
yeah, it's not
true. Yeah. Right.
Not true. I mean, you know, especially because there's a lot of alcohol use before surgery.
Right.
Right. A lot of people abuse alcohol, but without question, this is real with gastric bypass. You know, it increases your risk. And alcohol, you want to talk about your life not being better? Become an alcoholic. I had a patient come see me and ask for a reversal.
Wow.
Because he was an alcoholic. And it was a long and difficult conversation. We ended up not doing it. Anyway, so you metabolize it differently. It triggers receptors in your brain differently, and you're at risk. I counsel all my gastric bypass patients that there's about a 4 or 5% chance that I may make a strong recommendation to you that you never drink again. Mm-hmm. And you have to understand, like, that's out there. That's on the table. You might have to give up alcohol completely, not with friends, not ever, not one drink, not only beer or wine, zero alcohol may be the only way that you're able to control this addiction. And that, you know, that is a real problem. It's one of the things I absolutely worry about in my post-op patients. Not so much
with gastric bypass. I mean, I really see it in my friends who have, I mean, alcohol doesn't affect me differently than it did pre-op, but you know, I'm socializing more. I mean, I'm drinking more because I'm socializing more. And also it has an impact on my food choices when I'm drinking. So it's like, not only is it liquid calories, but it's also, you know, makes me eat things I might not.
Also inhibitions.
Yeah. But with RNY, I mean, I see a lot of people have very different reactions and sensitivities to drinking than they did before.
Yeah. I think another thing about alcohol, particularly for women, one alcoholic beverage can put you over the legal limit after surgery. And that would go for a sleeve too.
Even if you haven't lost all your weight? I mean, if you're...
Yes, it's got nothing to do with your body weight.
Oh, interesting. It's the weight. Yeah.
So, I mean, it might not, but it is possible. And you know, again, getting arrested for a DUI, that's not making your life better.
Right.
Another thing too, and this kind of dovetails into, I think, a really, really critical thing for all weight loss surgery patients to know, is that sugar sweetened beverages are very common in alcoholic beverages. That's how I have a lot of patients who never drink anything with sugar unless they're having an alcoholic beverage. And sugar sweetened beverages, without question, are the #1 risk factor for weight regain. Mm-hmm. And if you drink sugar sweetened, even after a Roux-en-Y, which is more resistant to weight gain than a sleeve, if you drink sugar sweetened beverages, you will gain weight. And
that's not just wine and champagne. Yeah. That's frappuccinos. That, you know, it's like you just generally
Kool-Aid, Gatorade, fruit juice, sweetened coffee drinks, mochaccino, frappuccino, pop.
Yeah.
Fruit juice. Yes, all of them.
So we got a question. I lost all the questions I sent you, so I don't know where they are. And
quick.
We don't have that. Yeah, we don't have that much time left anyway, so I'm going to go through chat. But what about carbonated beverages after surgery?
Myth.
Yeah.
Diet pop, and most carbonated beverages are either artificially sweetened or full sugar sweetened. Obviously, full sugar is off limits. I really try to discourage artificial sweeteners in patients too. But the LaCroix or club soda, great.
Do you know, honestly, I drank club soda all the time before surgery. And that was one of my biggest things was like, oh my God, I'm never going to be able to drink club soda again. Can I live? I drink club soda all the time. So at Obesity Health that was here in Southern California in October, Dr. Now from My 600 Pound Life gave a keynote. And he was talking about this like 5-year period where your metabolism is different post weight loss surgery. What are your thoughts on that?
Yeah, I think I think this all can be explained by the set point idea. That certainly the durability of the surgery, and again, this varies based on your genetics. There is a loss of durability for all of these surgeries over time. And with a sleeve, that probably starts more at year 2 or 3. With a Roux-en-Y, it's closer to 5 years. But at that point, you are certainly susceptible to some increases in your set point, much more so than you were before that time period. And that's really where a lot of the discipline becomes critical, because that's when you'll see the effects. And a lot of people in those first few years are like, I'm not doing everything perfect, but I'm okay. I'm staying the same. And they kind of assume, well, if it's happening at year 3 after surgery, it's just going to be like that forever. And it's not necessarily true. When they start gaining weight at year 5 or 6, like, I'm not doing anything different. Right? But you're not doing everything ideally either. So I think that's probably how I would describe it.
Yeah, I was rewatching some of your videos yesterday because I watched them when I was very newly post-op, and you were talking about this time after surgery and how, in the beginning year or so, you don't have the same, not only can you eat less, but you don't have the same mental cravings that you had before. So is that going to come back? That terrifies me.
That comes back.
It does. Wow.
Yeah, terrifying. And that's really where the hard work that you put in over the years immediately following surgery come into play. Because if after surgery, when you have no cravings, you get rid of the sweets, you get rid of the processed foods, you learn how to order in a social situation, you learn, what grocery stores you go to. When we go to a grocery store, we have the things we buy. That list has to completely change after surgery. Your go-to restaurants, your quick meals that you make, all of these things, all these decisions we make about food, about 200 a day, they have to change completely. And so if you do that when it's easy in those first few years, and that just becomes your new normal, then when you get out to 5 years and you're much more susceptible to the cravings, it's just, it's like you quit smoking 5 years ago and someone's like, you want a cigarette? No, I'm good. I don't need a cigarette. I haven't done one in 5 years. I have no desire for one. But obviously, if you were to take a couple puffs, you could be right back on it. And so it's really important to recognize that you are susceptible to redeveloping those old food addictions. And it's important to be extra disciplined about keeping them out of your life and keeping these foods at bay, so that your habits are what really keep you going over the long run.
Yeah, that's my soapbox, is just telling people to try to change their use that period of time when it's easy to really change your habits, and also to strength train. Those are when people ask me, those are the two.
Exercise, so effective for maintaining weight.
Yeah.
For preventing weight gain. Exercise forgives a lot of dietary sins.
Yeah. So a couple more quick questions that came in over chat. Someone asked, pre-surgery she was diabetic. Now after RNY she gets such low blood sugar levels that she passes out.
Hypoglycemia after Roux-en-Y, absolutely, real deal. There's 2 types of hypoglycemia. 90% of it is reactive, which means that if you eat something that has processed carbohydrates that are rapidly absorbed, your blood sugar spikes, you over-release insulin, and your blood sugar drops to a dangerously low level. And the treatment for that is obviously to not eat the processed food that triggers it. The best food you can eat to help maintain a constant blood sugar is beans. Beans are essentially a slow-release glucose tablet which keeps your blood sugar stable. So in patients who have a form of reactive hypoglycemia, and I have to really talk with them, what are the foods that you eat? Keep a log, check your sugars, let's kind of look over things. We can oftentimes find it's a granola bar, it's crackers, it's a piece of bread, it's something that's kind of not an ideal choice. It has a lot of refined carbohydrates in it that's in the long run triggering that hypoglycemic episode 90 minutes, 2 hours later. And so dietary modification, eliminating those foods, adding the beans in is critical. There's also patients who have something that's real called basidioblastosis, which is like your pancreas cells just over-release insulin. Thankfully, it's pretty rare. I don't know if I've ever seen a full-fledged dangerous case. And it typically, all of this also goes away around 2 or 3 years out from surgery. Mm-hmm. So we see it a lot in the first year. It doesn't happen right away. It's like year 1 to 3 that we see it. There's also a medication called acarbose, which is kind of like Xenical, but for carbs. It prevents you from absorbing the carbohydrates, and that can be a useful adjunct. So that if you take acarbose and you eat carbohydrates, you don't absorb them as fast, and so you don't get the spike. Again, I really focus more on the nutritional modification and using acarbose kind of for breakthrough symptoms. But it's real. Talk to your surgeon. They should. They're doing a lot of these. They're familiar with it, believe me, because it's out there.
Well, I want to be really respectful of your time. I'm so appreciative that you came out this morning. Is there anything else you want to tell people, or?
Yeah, I think first of all, when I release my book, I'll put some more videos out there. I appreciate everybody's patience. It's been probably over a year or so.
Yeah. Oh, I forgot. That was one of the questions. Was when's he going to make some more videos?
Yeah. Now, when I put out the new book, I'll make some announcements and I'll put out a series of videos. The truth is I kind of, when I look at them, there's not a lot that I still left uncovered. But if you guys see videos, see holes, one thing I was thinking about was pregnancy. I don't think I have a video on pregnancy, but especially there's some new science out there, and there's some issues with pregnancy. The common question, I definitely need a video on pregnancy. And if there's other videos, just go into my YouTube channel and make some suggestions. And when I finally kind of get them all together, I will. I'll start making some more videos.
Well, yeah, when I was looking at them yesterday, I'm like, well, this pretty much covers everything that we did have questions on.
It's fairly comprehensive. It did a great thing for my practice too, because all my patients are super well educated before surgery.
Yeah.
So that's the best patient. The best patient's the best educated patient.
I mean, my suggestion would be if you like maybe do an interview with your therapist in your office, that might be a
good idea. Yeah, for sure.
Yeah. So thank you so much. And thank you so much for all that you do for this community. It's really, really important. I feel like there's so many people who don't get the education that they need from their physician's office, or they're going to Mexico where there isn't a lot of follow-up, and YouTube has been huge for that. Just people sharing their experiences, but a professional coming in and spending this time like this is really, truly valuable to us. So thank you.
It's been my pleasure. It's really, I still love seeing the comments on the YouTube channel. I answer all the comments. So,
oh, you do? Oh, awesome. So yeah. I'll put links to all his information below in the description box of the video, and then you guys share this video, because I think it's important that people get information from an actual medical professional occasionally. Just saying.
At least to counterbalance the other stuff.
Yeah, just a little bit. It's a good idea. All right, thanks, guys. I will see. There's not going to be a Naked Truth this Sunday. I'll figure out when I'm doing another one, but we will see you all soon. Take care, everybody. Have a great Friday.
Take care. Bye-bye.